Welcome, everyone. On behalf of the Harbour Club of the United Kingdom, welcome to tonight's presentation by Carmel Shachar, Executive Director of the Petrie-Flom Center for Health, Law Policy, Biotechnology and Bioethics at the Harbour Law School. I'm Victoria Leung, a member of the board and events chair of the Harbour Club. Our club is an umbrella organization for college graduates and alumni from all the Harvard graduate schools. And this event is a collaboration with the Harvard T.H. Chan School of Public Health and a shared interest group in healthcare. So special thanks to Dr. Stefan Serban, who is here, for making all this possible. And thank you to the team of the School of Public Health. And this includes David Rogers, Marielle Boudreau, Megan Duffy, and Amelia Clues for facilitating the logistical and technical side. After the presentation, Carmel will answer some of your questions. And if you want to ask a question, please post it by using the Zoom Q&A feature. And I'll turn it over to Stefan. Thank you.
Thank you very much, Vicky. Hello, everyone. My name is Stefan Serban. I'm a specialist registrar in dental public health at NHS England, and I'm serving as the chair of the shared interest group in healthcare of Harvard Club UK. It is a great privilege to introduce our distinguished speaker, Carmel Shachar. Carmel graduated cum laude from Harvard Law School and obtained her master's in public health from Harvard T.H. Chan School of Public Health. She's the executive director of the Petrie-Flom Center for Health, Law Policy, Biotechnology, and Bioethics at Harvard Law School. Carmel's scholarship focuses on law and health policy, in particular the regulation of access to care for vulnerable individuals, the use of telehealth and digital health products, and the application of public health ethics to real-world questions. Her work has been published in prestigious journals such as the New England Journal of Medicine, JAMA, the Hastings Center Report, the Nature Medicine. She has been interviewed and quoted in venues such as BBC News, Politico, CNN, and Slate. She has co-edited several books published with the Cambridge University Press, including Transparency in Health and Healthcare in the United States, Disability, Health Law and Bioethics, Consumer Genetics, Ethical and Legal Considerations of New Technologies, which is forthcoming, and Innovation and Protection, the Future of Medical Device Regulation, also forthcoming. Without further ado, Carmel Shachar.
Thank you so much, Stefan, and thank you, Vicky, as well as the rest of the team for hosting me for this very interesting talk. As Stefan went over my bio, but to give you a little bit more insight about why I am the talking head on Zoom today for this topic, which is no jab, no job, ethical considerations of vaccine mandates. I have been trained in both public health as well as in law. That's actually the 2 degrees behind me that I put there for visual interest. And up until, I would say, March 2020, the way that I would describe my training in my career is that I really loved my time at the Chan School. I learned a lot, but every job that I've gotten because of my degree from the law school rather than the School of Public Health. And then all of a sudden in March 2020, not coincidental with the pandemic, people started being excited of having me in the room because of my training in public health. And I think that this is a really important and exciting development because for the last several decades, I think we've talked a lot about healthcare as the individual medical treatment, and we've given relatively little thought to the endeavor of public health, which is a much more communitarian, social-wide endeavor to try to raise overall the health of our communities. And while I certainly don't hope for a pandemic, it's caused an immense amount of human suffering and loss of life, I do think that revisiting public health ethics has been a silver lining throughout this whole experience. So with that, I'd like to spend the next little while talking about some of the ethical factors that go into vaccine mandates, both arguing in support of vaccine mandates and arguing against vaccine mandates. Next slide. So to give you a taste of where we're going to go, and you can look at this slide and think, gosh, this is not for me, I'm going to instead log off and get a sandwich, that's fine, but hopefully you'll find it as exciting as I do. First, we're going to talk a little bit about why we might or might not want vaccine mandates. We're then going to dive into the meat of the presentation, which is what is the legal framework for vaccine mandates and how is it informed by ethics? And two things to pick out there. I'm aware that this is an international audience, especially with involvement of the Harvard UK Club. And what we'll see is that the actual legal analysis might be a little bit different, but it's all got the same underpinnings, which is an underpinnings in ethics and bioethics. We'll also discuss healthcare employment-based vaccine mandates as a special case where I think some of the justifications for vaccine mandates are a little bit heightened. So if there was ever a time that the justification for a vaccine mandate kind of rose above that necessary level to trip its imposition, it would be there, as well as talk a little bit about what alternatives to vaccine mandates might look like. Next slide. So first might come the obvious slide, why vaccine mandates? And you'll say, okay, well, I'm pretty sure I have a good sense why, but I think it's important to get on the same page. The vaccine mandates are some of the strongest incentives we have to get people mandated. Time and time again, we see evidence that vaccine coverage increases utilization of vaccines. And we see this especially in the context of vaccine mandates for various childhood diseases, because vaccine mandates are very commonly tied to school attendance. You see this in France, you see this in Italy, you see this in Germany. The United States is a great example in that it's state-based, so the requirements in Massachusetts and the requirements in California can look a little bit different. Some states are more generous with their exemptions to the point where there effectively isn't a mandate because you don't even need a medical or religious reason to object. You can just say as a parent that you have a philosophical objection and nobody will dig too deeply into it. And when that happens, we see that vaccine rates in the community really do plummet to the point where, there are measles outbreaks in places like Oregon and California. Vaccine mandates also avoids decentralizing decision-making. And here the point is that even in the absence of a countrywide or statewide vaccine mandate, you'll still have pockets of vaccine pressure. So it may look, for example, like a major employer saying, if you want to work for us, you have to be vaccinated, or school mandates. But it becomes more and more difficult as smaller and smaller actors are asked to stand on their own here, or as organizations that don't have a lot of public health expertise are asked to determine, would vaccine requirements be right for my employees, my students, my clients, the population I work with. In general, and this is a theme that we'll return to again and again, vaccine mandates work best when there's a surge of infections, when people can really see, oh, if I don't get this vaccine, I could get this disease, as well as when vaccine confidence is lower, or to put it in slightly different terms, when there's more vaccine reluctance, but not necessarily hardcore opposition. Next slide. So here I'm going to take a page out of my 2.5-year-old son's playbook, because like most toddlers, he really learned to love the question why. But now he really likes the question why not. So in his honor, I'm going to go through a slide, why not vaccine mandates? The first and by far the largest objection is that vaccine mandates infringes on individual liberty and bodily self-determination. There are very few other situations in which we as a society require people to take medications against their will. There's some often mental health exceptions where the idea is that a person may not have full decision-making capacity, and if we stabilize their situation, they could return to full decision-making capacity, where we'll allow for perhaps court-ordered medication. But in general, we find it very disquieting to say, okay, you as an individual cannot determine what goes in your body. vaccine mandates can also be counterproductive. And here the example that I like to give is the even older than that, 1853 riots in England, which was sparked by the National Vaccinations Act that was very strict and very onerous. Those riots really pushed back on the Vaccination Act, and it was actually replaced with something that had a lot fewer teeth. So would it have been better to have, in the first place, an act that was a little bit more loosey-goosey or allowed for more exemptions so you wouldn't get those riots and you wouldn't get the pendulum to swing all the way in the other direction? Perhaps, I think you could make a strong argument in that direction. And sometimes education can be more productive instead of merely telling people, well, you have to do this. To go back to the discussion of my son, the toddler, what's appropriate for telling a toddler, you have to go to bed, you have to eat your dinner, does not really work for fully grown adults. And so educating them to say these vaccines are safe, here's the importance of it, here are, for example, people who are at risk if you don't get vaccinated, can often have quite positive results. It's for these reasons that the WHO argues that mandates should actually be a last resort policy, not a frontline policy after all other initiatives have failed. Next slide. So we're now going to dive into what are some principles that allow for vaccine mandates. And I think this quote really summarizes a lot of things that we're going to dive into. This is from Jacobson v. Massachusetts, which was a 1905 case that is really the governing case when it comes to vaccine mandates in the United States. There, the court said, "The liberty secured by the Constitution of the United States to every person within its jurisdiction does not import an absolute right in each person to be, at all times and in all circumstances, wholly freed from restraint. There are manifold restraints to which every person is necessarily subject for the common good. On any other basis, organized society could not exist with safety to its members." The idea is we are all people in society, and sometimes that means that our will, our preference cannot be acted upon because it needs to be sacrificed to the common good, perhaps the greater good. Next slide. So one point that I want to make is that vaccine mandates have long been culturally controversial. There's a lot of debate over whether vaccines are okay, whether people who refuse them are good citizens, but they're not legally controversial. And here I will refer back to a panel that I did in about December or so on vaccine mandates. And it was myself and Art Kaplan, who is a very noted bioethicist, and Larry Gostin, who is a very noted public health law expert. And I felt a little bit bad for the organizers of that panel because they did a lovely job pulling it together, and they had Art and Larry and myself, and we just agreed with each other. There wasn't a lot of dynamic tension in the panel because basically Art, Larry, or myself would say one thing, and then the other two would say, yes, I agree. And some of that is because, like I said, the legal framework for vaccine mandates has been settled a long time ago in 1905 for the United States. And it's been a little bit of a legal backwater ever since. Vaccine mandates are even less controversial for some populations. The classic examples are vaccine mandates for children, often tied to school attendance, and vaccine mandates for healthcare workers, which, as I promised, we'll get to in a little bit. In general, though, the trend in health law is to emphasize individual autonomy and self-determination. We are moving the pendulum away from medical paternalism, and we really want people to be able to make the right decisions over their own body. We want there to be informed consent. We want people who need support in their decision-making to have that support so that they can make their own decisions. And in this regard, the law around vaccine mandates might be a little bit out of step with modern health law and modern bioethics. Now, at the beginning of this slide, I said, oh, there's not a lot of controversy in the legal sphere. It's very straightforward. Art, Larry, I, and a host of other health law scholars all agree with each other. But I think that this statement is true right now. But if you talk to me in a few months, I think that it might not be as true. So that is to say, there are several cases that are pending before the United States Supreme Court. And I think that we might see a real change where all of a sudden this very broad vaccine mandates are legal as long as the right state actors implementing them gets pushed back on in response to COVID-19. Next slide. So in this framework, I'm going to discuss some criteria that are often used by the courts to assess the reasonableness of limits on individual freedom. And these concepts often go by different names depending on which jurisdiction we're talking about. But these principles can really be boiled down to proportionality, precedent, context, and sufficiency of access to the good or service being mandated. Next slide. So let's talk about our first principle, proportionality. In general, higher levels of risk justify more restrictive limitations on individual freedom. So here, COVID obviously meets that level. COVID is a terrible disease with some really high death rates, especially in older populations, in people with pre-existing conditions. It's not a disease that you want to get, that you want your grandmother to get, and that you don't really want your healthcare system overrun by COVID. But here's where it starts to get less clear-cut. Omicron famously is less severe and less risky than the Delta variant. So is the ethical and legal justification for COVID-19 vaccine mandates, does that change depending on what the dominant variant is at the time? Does it change with treatments? There have been several treatments developed that if you can access them and take them at the right time in the course of your COVID-19 infection, can really bend that mortality curve. Do we need to factor those in? What about hospital capacity? Part of the issue with the COVID-19 pandemic is that hospitals get very overwhelmed very quickly. For example, in the beginning of the pandemic, you had reports about nurses and physicians trying to figure out homebrewed ways to have events service multiple patients. But if there was sufficient hospital capacity, would that change the justification for a vaccine mandate? I also want to say here that risk can be thought of in many different lenses. It's your own individual risk. So if you are higher risk for complications or for death from COVID-19, is there a heightened ethical obligation to be vaccinated so that you won't take up more healthcare resources than you need to? But there's also that social risk. We don't want to risk our healthcare system getting completely overrun by COVID-19 patients. And so you may have that ethical obligation to be vaccinated to avoid that risk to society, as well as just the risk of passing it to more vulnerable people. Next slide. The next principle we'll talk about is precedent. And precedent is commonly thought of as, okay, what cases happened before that we've decided? You could think of precedent as if we have a flu vaccine mandate, why not a COVID-19 vaccine mandate? But you can also think of precedent as essentially what else have we tried to solve this particular pandemic or epidemic? Have we tried less restrictive means of getting people vaccinated or of having them avoid infection? And in general, unless there is an immediate severe risk, adults should probably be free to exercise their autonomy to the extent that vaccination rates afford sufficient public protection. Next slide. A third principle is context. And here, I'm actually really delighted that we have an international audience, especially, I suspect, a large representation from the US and a large representation from the UK. Because even though these two countries share a common history and share a lot culturally, there have been a very different response to the COVID-19 vaccine. The US is famously resistant to the COVID-19 vaccine. We have very, very low vaccination rates here. And that's in part because the COVID-19 vaccine issue has become something of a political litmus test. And so people aren't really making decisions based on what's right for themselves and their family and the health of their communities. They're making it on how do they identify politically. And I say that both for the right and for the left. And so we may want to move carefully with vaccine mandates in the US because there's very little trust of our public health system, of our public health leaders, of our healthcare system among large groups in the population than we may in a country that is overall more supportive of vaccination. Next slide. The last is sufficiency of access. So you can't require that everybody go out and get something if they don't have access to it. And here, in general, the US and the UK have done a good job of making sure that the vaccine is available to all of its citizens and often people who are not citizens. But I would urge people to think about this also in the context of global access. Before Omicron made it clear that to have some measure of protection against it, you really should have that third booster. Boosters were a prime example of this. There are many parts of the world where access to these vaccines is hard to come by. And is it the best use of our vaccine capacity to direct vaccine doses to the booster shots, third shots for people in countries with relatively low COVID rates? Or would it be better to direct those supplies to vaccinate other countries that have much lower access to it? There's also discussion of sufficiency of access when it comes to the types of vaccines available. So the mRNA vaccines perform better than a lot of the other COVID vaccines being developed. Is there an obligation with a vaccine mandate to try to ensure access to the mRNA vaccines, even though they are more expensive and logistically more challenging to distribute because they take multiple doses, they often need to be refrigerated at very cold levels? My point with this slide is really, you can't, when it comes to public health law and ethics, get too abstract. You need to really apply it in the context in which you meet people and in which you meet societies. Next slide. So I'd like to dive in a little bit to the special case of healthcare workers. We have had vaccine mandates for healthcare workers long before COVID-19. For example, many states in the US require healthcare workers to get a flu shot each year. The story of vaccine mandates among healthcare workers in the US as opposed to the UK, I think, is an interesting contrast. The US implemented a vaccine mandate among healthcare workers, where what it did was the Department of Health and Human Services said, if hospitals, physician groups, other medical organizations want to get money from Medicare and Medicaid, which are our two government payer programs, you have to get basically all of your healthcare workers vaccinated. The Supreme Court hasn't fully heard this case. I won't get into all of the procedural things that I think are interesting to legal nerds such as myself, but get very complicated quickly. But they did hear whether this vaccine mandate should be implemented in the time that it will take the court to be able to fully hear this case. And they said that Health and Human Services should be allowed to enforce nationwide this vaccine mandate among healthcare workers. And they justified this by emphasizing that a key responsibility of the Department of Health and Human Services is to ensure that healthcare providers who care for Medicare and Medicaid patients protect their patients' health and safety. So they really grounded it in, this is a healthcare issue and you have an obligation to your patients. By contrast, that same day, they heard a similar case, which was another vaccine mandate case, but in this case, the federal government requirement that all employers who have at least 100 workers get their workers vaccinated. And there they said that agency could not enforce that vaccine mandate until the court heard the full case, because they felt like it wasn't, having 100 workers was not sufficiently related to the need for a vaccine mandate. And so they weren't sure that it would survive the legal challenge. So in the US, Supreme Court is giving some really positive signals about a nationwide vaccine mandate. Next slide. The UK government originally was on a really similar track to the US. So it initially implemented a vaccine mandate for healthcare workers, but then all of a sudden it gave a reversal on January 31st. And the reasons given were that Omicron, the dominant variant, is milder. Vaccines were no longer as protective against infection. They are very protective against developing severe illness, long COVID, or dying from COVID-19 when you do get it. But unlike previous variants, it seems like being vaccinated does not really protect you from being infected or from infecting other people. And the reason given was it is no longer proportionate, which really harkens back to that first principle that I talked about, proportionality, which brings me back to my point that when it comes to public health, what is ethical and what is legal often have a lot of overlap in that Venn diagram. Next slide. Speaking of that, so let's talk about healthcare workers and some specific wrinkles with them. So healthcare workers aren't just random people off the street. They are professionals who have a fundamental duty to minimize risk to their patients. So the Hippocratic Oath says do no harm. If I was a physician seeing patients and I gave them COVID, I would probably be doing harm. I think we could all agree there. The other thing is that, in the last 2 years, I have worked from home really successfully for long periods in which I interacted with a lot of people, but I saw nobody physically. Healthcare workers don't have that opportunity. They really do need to see people in person with the exception, some limited exceptions of telehealth. And so they are both quite likely to be exposed to COVID through working with their patients, as well as expose patients to COVID. One question I want to raise is that in light of the ethical imperative to do no harm, is a healthcare-focused vaccine mandate truly needed? And here we get to the difference between legal requirements, what should I be compelled to do by my government, and ethical imperatives, which is what should I do as a member of society? Now, there is a lot of surprising resistance to COVID-19 vaccines in healthcare workers, particularly as you kind of go down the medical hierarchy. You see that the medical professions associated with less education, in particular, tend to have higher rates of vaccine refusal. And so you might argue that in a perfect world, healthcare workers would obey that fundamental duty to minimize risk to their patients, but in the real world, they often don't. And so a healthcare-focused vaccine mandate may still be necessary. Next slide. But as I mentioned at the start of my talk, a vaccine mandate isn't our only tool. It's a very strong tool. It can be an effective tool if used properly, but there might be other ways to go about it. Here I want to distinguish between vaccine mandates and vaccine credentialing, where I like to think of it as vaccine mandates with benefits. So it's not just saying, okay, you, because you are a person in society or because you are a special type of person in society, you are a healthcare worker, for example, need to get vaccinated. We can say, all right, if you want an access to this social good, and the social good might be something as kind of simple and pleasurable as going out to eat in restaurants, you need to be vaccinated so that you can show that credential to get in. I think the best example of that is the Israel's Green Pass, where you load it on your phone, and if you want to enter places, you show that you've been fully vaccinated and you can go in. Private actors can impose vaccine credentialing. So for example, I work for Harvard University, and Harvard has said, if you want to be a member of our community on campus, you have to be vaccinated. And we have to see proof of your vaccination before we will let you back on campus. So you could see a society in which the state of Massachusetts doesn't require everybody to be vaccinated, there's no vaccine mandate there, but I myself am part of a vaccine credentialing scheme. Now, at a certain point, vaccine credentialing looks, feels, functions effectively identical to vaccine mandate. I don't need to work for Harvard University, so it's a credentialing system, but if all employers required vaccine credentials to be employed by them, then it would really feel like a vaccine mandate because I need to work in order to pay my bills. Another question I want to raise is often we focus on vaccines as the documentation that we want to see, but there's a lot of evidence that past infections can build some sort of immunity wall. And you saw that, for example, in South Africa with the emergence of Omicron, where a lot of public health experts and epidemiologists said, we don't fully know how Omicron will play out in the US and in the UK and other countries because South Africa has built a bit of a firewall with past infections. So when we talk about vaccine requirements, be they vaccine credentialing or vaccine mandates, should we really be talking about immunity certificates? Saying if you can prove that you had a COVID-19 infection within the last 90 days, you get more leeway to be out and about in public. Right now, there's a lot of discussion in the US about dropping masking requirements, but should those be thought of in tandem with vaccine rates and vaccine mandates? That is to say, if we don't want a vaccine mandate and we're willing to accept very low rates of vaccination, do we still need to keep vaccine mask mandates when people go out in public because of the greater risk to the community? Next slide. There are some other ethical issues because mask mandates are not inherently discriminatory, but like most public policy efforts, the way that they can be applied can result in disparities and discrimination. So we know certain groups are more likely to be vaccine hesitant. At the start of COVID-19 vaccine administration in the US, those two groups were largely identified as communities of color, especially African-American communities that had a longstanding and very rightly justified distrust of the medical community after such inglorious examples such as Tuskegee, as well as communities that were white and much more right-leaning, had a strong distrust. Do we feel differently if your objection to the COVID-19 vaccine comes because you as a patient of color have been really minimized and poorly treated by the medical professionals you've interacted with versus somebody who may be immersed in, say, an online group that is spreading a lot of alarming information about vaccines? Do we care about the reason that people are vaccine hesitant? And do we consider some reasons to be kind of more worthy of respect or understanding? Then there's also the question of, will some people simply be left out if we're requiring vaccine mandates? Does everybody truly have the ability to access those vaccines and to have that documentation? Because it's not good enough to merely get it. You want to have the right documentation to prove that you're complying with it. I especially raise this because I think a lot of countries have moved a lot of their vaccine credentialing to smartphone applications, which makes a lot of sense. I will say the US goes by what amounts to basically an index card with the CDC written on top, and then they write in your vaccine administrations. And it feels kind of silly because that index card is in my wallet right now, slowly disintegrating each time I pull it out. And if I lose it, I have no way really to get it. I have a copy on my phone, but it's just a picture that also feels silly. That's easy to fake. But if you have everything be on a smartphone, that presupposes that everybody has a smartphone. And we know that's not true, or lower income families often share smartphones. Next slide. So this last slide I would use to illustrate the point that, which I mentioned before, that with public health law and ethics, you need to really think about the underlying situation. It needs to be very applied. But it also goes to show how rapidly things change or don't change in the pandemic. This slide is actually from a presentation I gave maybe about a year and a half ago, as I talked through vaccine passports, which is kind of similar to vaccine mandates in that it's a credentialing scheme that pushes people to get vaccinated. And I made the point that before we implement these passports, certificates, whatever you want to call them, we're missing a lot of information. Then for a while, I didn't really use this slide because I thought that we actually had the answer to a lot of these questions, that we knew that people who were vaccinated were much less likely to transmit COVID-19, that the protection offered against Delta, for example, was pretty good. And then Omicron came along, and a lot of these questions that had answers or had sort of reasonable enough answers to say, okay, we can figure out a scheme that would be fair, all of a sudden didn't really have answers anymore, or those answers really changed. So with Omicron, vaccinated people can and do frequently transmit COVID-19. And so does that change our analysis of the vaccination credentialing system? And I bet that if I use this slide in 6 months, the answers to some of these questions would be different than they are today. And if I used it again in a year, the answers might be different than today and from 6 months from now. So this goes to my last point, which is that I think imposing vaccine mandates or vaccine credentialing and then undoing it, as some countries are doing, creates an interesting setup, because once you're vaccinated, you're kind of vaccinated for life, or at least you've had the thing happen to you. So if I'm a healthcare worker and I get vaccinated because I see this vaccine mandate is coming up and I want to keep my job, even though on the whole I'd prefer not to be vaccinated, and then that mandate goes away, the damage, so to speak, is done. And so unlike mask mandates that we could impose and lift and impose again, and really the only negative externality is I might have thrown away my masks and need to buy new ones, with vaccine mandates, it feels important to run through the calculus and try to balance all of the ethical principles based not only on the answers that we have in this moment, the answers we might give to this slide right now, but also to the answers 6 months from now or a year from now, because once people are vaccinated, they can't really unring that bell of having gone through medical procedure that they may or may not feel comfortable with. Next slide. So with that, I know that I've been asked to reserve some time for questions and answers, and I'm really looking forward to your questions. I think this is a really important topic and a great lens by which to think through your own personal relationship to public health, as well as your obligations as a member in society, perhaps a healthcare worker, perhaps a parent of children who need to be vaccinated to attend school.
Thank you very much, Carmel. That was really fascinating presentation and a lot of food for thought. We've got a few questions here. How would you prefer? Do you prefer we read them, or would you like to go through them?
Why don't you read them so that
Okay.
people can also hear them and I don't sound like I'm talking to myself.
Sure, thank you. Vicky, would you like to do one? Would that be okay?
Sounds good.
Perfect, thank you. So
Fire
let's
away.
see.
You take the first one.
There was a question from Jose asking about airlines and other means of public transportation and other agencies who require vaccination for travelers. I presume they mean the mandatory vaccinations when you travel in certain countries as well. There are some parallels, I think, there.
So vaccinations for travel, I think we can break it up into several buckets. There's, should you be vaccinated in order to physically be on the plane? Now, a lot of what I've seen suggests that airplanes actually have quite good air circulation. So unless you're unlucky enough to be seated next to the COVID-19 positive traveler, if you're several rows down, chances are you won't get COVID-19. But having recently ridden the Boston subway, I can say if you're sitting in a subway car for basically anything more than one stop, with other people, chances are you'll be exposed. So depending on the method of travel, I think that it can be justified. Now, I think the other bucket is when you arrive at that destination. Should you have to be vaccinated in order to enter the country, even if that country doesn't require its own citizens to be vaccinated? And I think the US is a good example of it, where they often say, if you're coming in from outside the country and you're not a citizen, we want you to be vaccinated. There, I think it goes a little bit to who is the community trying to serve there. I think it's very reasonable of countries to say, we would like to give our own citizens a little bit of leeway because they are members of this community, but you, person who are not a member of our community, your presence here is kind of optional. I mean, it could be a business trip, maybe it doesn't feel optional to you, but chances are, from the perspective of the society you're entering, it is optional. And so they can say, we don't want you to become a burden on our healthcare system or to spread COVID in a way that will become a burden on our healthcare system. So we are going to heighten the requirements for you as opposed to our own citizens.
Thank you.
Yeah, that's really interesting. So the next question is from Peter Sanford. You might have mentioned this already, Carmel. So when you talked about the counterproductive effects of vaccine mandates, he pointed out that there is the risk that they empower hard-right anti-vaxxers and also induce progressive politicians to burn through huge amounts of political capital. And certain countries like New Zealand already have a very high vaccine coverage, so mandates should simply be unnecessary. So this is Peter's point. Do you have any comments to that, please?
Yeah, so I think in some ways, what societies will respond well to vaccine mandates, it's a little bit of a Goldilocks problem. So New Zealand, everybody seemed really eager to get the vaccine. I will say, where I sit in Cambridge, Massachusetts, there's extraordinarily high vaccination rates. There did not need to be a mandate here. Getting a vaccine for the first several months of the rollout was extremely difficult because everybody wanted it. But when I travel up an hour or two north to, say, rural New Hampshire, where people are much more spread out and there's a little bit more of a libertarian culture, there's a lot more pushback. And so you don't want to put a vaccine mandate in a society where people are already getting it. I mean, you could, but it just won't really matter. And you also don't want to just nakedly put it in a society where the majority of people are inclined to push back on anything that feels too authoritarian. I think it's in societies that are kind of teetering, where there are a good number of people who will get it, but there's a population that's essentially undecided. That's where vaccine mandates can be most effective.
Yeah, great. Yeah, that leads to actually an observation of mine, because I mean, anybody visiting a country like New Zealand, for the government to want to protect their own citizens, they would have to require some sort of certification from visitors that they are vaccinated. So, again, it's back to the point you made to the previous question.
Yeah, absolutely. I think New Zealand has a really good justification for saying, if you want to visit lovely New Zealand, which I would love to do at some point, you need to show that you're vaccinated to match the expectations of our community.
Thank you. Another question here from William. How is ethical or legal to fire someone who has natural immunity from prior infection? So getting immunity from infection rather than from vaccination.
So I think that depends a lot on the particulars, both on the effectiveness of the vaccine and how it stacks against natural immunity. So I think on the whole, the medical evidence suggests that natural immunity is good. Vaccinations are better, or at least a little bit more durable. It seems like natural immunity kind of has, for most people, like a 3-month shelf life. And after that, it's past its prime, as well as what kind of workplace you're in. So if you're in a workplace where you're working remotely and your employer says, well, we'd still like for you to get vaccinated, that's a little bit less justifiable than if it's a workplace that is bringing everybody together and people are working closely, like, for example, in a meatpacking plant. Now, the truth is that I am not an employment lawyer, but what I do know about employment law in the US as contrasted to the UK is that the US, most states are what are called at-will employment. So unless I fit into a protected class, my employer can fire me for pretty much whatever. And we don't sign employment contracts. So, Harvard could be like, this has been really fun, but it hasn't been that fun. So goodbye, don't come in after Tuesday. I think the UK and the EU, it is a little bit different. The expectation is that employment is a little bit more durable and that there need to be better reasons for termination and dismissal. And so that changes, again, I think a little bit of the calculus of whether an employer should be able to fire you for saying, well, I had COVID and I think that is sufficient protection. I declined to get the vaccine.
Thank you.
Yeah, the next question is from Lotte Ehring. It's about the unethical wastefulness of making everybody get vaccinated in countries that do not need the vaccination as badly. So I have to scroll through this because something just, yeah, right. So there was a moment in certain countries when a certain portion of the adult population was boosted while a portion was not vaccinated. So he's asking, is it not possible to close the gap by having a vaccine mandate so that everybody gets, one jab? Isn't that more ethical and less wasteful than boosting those who willingly take the vaccination?
So I think here is where we get into what level of human society are we implementing these vaccine mandates? I think in a perfect world, we would say we are all interrelated, we are all interdependent. Vaccine that most likely arose in Wuhan, China, now impacts people in London and people in New York and people in San Francisco. And so we need to think about access to vaccines on a global level. And it should be just as much of a priority to get access to vaccines for a person in Bangladesh as it is to get vaccines to a person in Texas. That is not the level by which we make our determinations of vaccine mandates. So we make them at the country level, negotiating with manufacturers how many doses each country gets. And we often make them at a lower level, at a province or state level. And there, I think it becomes a little bit more complicated because it's almost a zero-sum game where if I'm Massachusetts, I can't necessarily say to the federal government, no, I don't want to accept this vaccine shipment to boost my population. I'd rather it go to people in Brazil to make sure there's more equitable coverage, because then it might just get snapped up by New York. So I think some of the answer to that is that right now, our political structures are set up to prioritize people, especially at the country level, as opposed to at the global level.
Thank you.
Thank you. Lots of questions are pouring in. I'm trying to combine some of them that share a similar theme. One question from Remus that I think goes together with a few others around the seriousness of vaccine mandate enforcement and how it affects the trust of the population once vaccines are being enforced.
So I think you want to walk a fine line here. And I think that the example of childhood vaccinations is a really good illustrative one, because what you see is that there are a lot of parents who are really worried for their children. You want the best for your kid, right? And unfortunately, a lot of developmental issues often come to light around the same time that children are getting the majority of their vaccines. So my son, the toddler, just went through a gauntlet where every appointment we showed up at, it felt like he got 3 shots at minimum. And, he cried and cried, and he probably napped a little bit more in the following day, which was great for me. But you can see a story where he gets these shots at the same time where we may be picking up, okay, is his language developing appropriately? Is he making appropriate eye contact? And then you can easily build this narrative on a parent who feels anxious about, is my child hitting their developmental milestones the way that I would want them to, by saying, okay, maybe it was this thing I gave him. Because the hard thing about vaccines as opposed to medical treatment, and I think the reason that you see a lot of anti-vaxxers who get COVID and then go to the hospital demanding treatments that are far more experimental than the vaccines are, is that when you're really sick, you're willing to accept a lot of side effects. Like if I am COVID positive and I'm struggling for air, give me whatever pill Pfizer is working on. I don't care if it hasn't been tested in humans. Like I can't breathe. But if I feel perfectly fine, I'm going to feel very hesitant about getting a vaccine that will make me feel like I have the flu for the next day or so. That's kind of the way that our minds are built. And so I think that it's really important to educate people, for example, about what to expect with side effects. In the parent population, I think a lot of work was done to say, you know, these vaccines are really safe. They don't cause issues such as autism, but chances are if your child does have autism, we may see it at the same time that we give vaccines and try to separate that out for people. And that's why I think you can't just have mandates, you also need to have a lot of education campaigns.
Makes sense. Thank you.
Yeah, I think that partially answers the next question, because Alicia is asking about the role of the spread of disinformation and how that impacts the ethical considerations of mandates. And I think you partially answered that, but it's very thought-provoking. If you have anything to add to that.
Yeah, I mean, I think that the role of health disinformation is a really interesting one, and that's one that my center has handled, for example, in past events where I think we have the video online. And I think that technology companies need to really take responsibility for providing a public forum for both useful information as well as disinformation. And I think it's not a health issue, but it is really interesting, the response of, say, Facebook to the conflict that's happening in Ukraine with Russia, where they're saying, okay, we as a platform don't want to host certain actors and we don't want to be present with certain speech. Because I think that they have been really thinking about their role in providing an avenue for disinformation from the COVID-19 pandemic, and they have been applying that past experience to this current conflict.
Absolutely. And some argue that warfare started many years ago in many walks of life. An interesting question from Peter that may not be relevant for the USA about, but could be for the UK, about a moral hazard issue, because when healthcare is funded from general taxation, unvaccinated people make disproportionate use of the publicly funded resource, e.g. intensive care beds, but do not pay any more than anyone else for those services.
Yeah, so I think Peter brings up a good point. I've often used that 80-20% rule in the context of healthcare spending, that 20% of the population consumes about 80% of healthcare spending. And, you know, there have been a lot of discussions about if you have refusing the vaccine and you get really sick and you go to the hospital, should you be deprioritized for medical intervention? And we don't do that in a lot of other cases. So, for example, if you get in a car accident and you get rushed to the hospital, we don't stop to ask, okay, how many drinks have you had? Were you paying attention? Were you texting on your phone? Was it the other driver's fault? We just treat people. And some of it is because, you know, healthcare providers have enough on their plate already to have them try to be some sort of moral arbitrators as people walk through the door is really difficult. On the other hand, I will say, like, I know I feel very frustrated hearing reports of people who necessary surgeries and necessary healthcare procedures are being postponed because hospitals are overrun by people who are COVID positive, especially when the majority of those are unvaccinated. And so I do think it is a fair discussion to have to say we only have so much of the healthcare pie. How much should be devoted to people who have chosen to make themselves more vulnerable to consuming more in this case?
Thank you.
Yeah, thanks very much. There was a question which actually disappeared from my screen now. It's by Stephen Shana, and I just want to bring it up because it could well be answered. And if Stephen doesn't think so, if he could, type another question, that would be great, because he raised the issue of insurance companies. To what extent insurance companies are obliged to pay for the treatment of those who refuse to get vaccinated? That's what I recall from the question. Again, it's disappeared from my screen. Okay, so I'll go on to the next question, which is still there. It's a question from Julian Thomas. Do you think the deck is being stacked against the aged population, i.e. those who are 80 and above?
So I think it depends what, Julian, you mean. I would say biologically, is it a great time to be 80 in society? No, I would say that it's probably a pretty poor time to be 80 plus in society. Even people who are over 80 and vaccinated do have significant risk from COVID. And that gets into, again, the fact that vaccination is not just a personal choice, but it really needs to be a public choice. So people who are older, even if they are personally vaccinated, need that firewall protection from other people being vaccinated. Even if with Omicron, you can be vaccinated and get Omicron fairly easily, it might shorten it, it might lower your viral load. And so it's important to do that. It's also important to do it from the context of, if I can be vaccinated and even if I get COVID, it keeps me out of the hospital. So there are those resources for the 80 plus crowd. That is also really important.
Thank you. Also conscious of time as well. I think maybe we can collect some of the questions later on through the alumni club. And perhaps we can send them over, or they can read some of your publications where you answer in more detail some of those questions. Should we bring to a close the webinar? And thank you so much, Carmel, for a very, very informative presentation. It was a great privilege to listen to your presentation, and it will inspire us to consider and to reflect on the ethical implications of vaccine mandates, both professionally and personally. Harvard Club UK and the Special Interest Group in Healthcare always welcomes collaborative events between alumni groups from different Harvard schools. Thank you to Carmel once again for representing the School of Public Health and the Law School. Many thanks to my co-host, Victoria Lung from Harvard Club UK, Dr. David Rogers, Marielle Baudreau, Megan Duffy, and Amelia Klaus from the Office for Alumni Affairs of Harvard T.H. Chan School of Public Health. And to you all, our members and our guests, thank you for coming, and we look forward for the next time. Thank you.